And we're going to get ready to start a live spine surgery. This patient has back pain. It goes into both legs, left and right. He has herniated discs at several of the discs in his lower back, 3 of them. And when I examined him and interviewed him, I made the determination that these 3 discs are causing not only his back pain, but also his leg symptoms. We're going to get started, okay? Now our patient is laying here on his belly with his back exposed. And when I asked him, where is your back pain? He told me it's in this area right here. So I had him point out where the pain was. And, you know, he had bad pain at the bottom here where the L5-S1 disc is. Then he had pain above. He pointed here, and he pointed there. And this is the L3-4. So L3-4 disc, just lay still. L4-5, L5 and S1. Now discs are soft cushions and they're named based on the bone that is above them and below them. So the L5-S1 disc is the disc between the L5 bone and the S1 bone below. He has tears at L3-4 on the left, L4-5 on both sides, and L5-S1 on the right side. And this is his right side. This is his left. How long has he had back pain for? Are you awake? How long have you had back pain for? All right, so he's slightly sleepy. He had 5 years of back pain?
Yeah, about 5 years. Yeah.
Okay.
It's like every 2 to 3 months it flares up.
Yeah, 5+ years. And his back pain is like everybody else's. It's in the lower back around the belt area. It's debilitating when it flares up. Sometimes it gets better on its own when he takes it easy. But then when he starts doing things, it flares up. And he found Deuk Spine Institute. He talked to me, wanted to know if I could fix his back pain, fix these discs with the laser surgery, and I said yes. So here he is. He's traveled from Canada, and he's here to have his back fixed. All right, we're going to start on the left side. I'm going to give you some numbing medicine, okay? Just lay still. So I'm going to go ahead and numb up the area that I think is where I'm going to go in with this needle. And the numbing medicine is going to help. It's a little uncomfortable going in, I understand. Okay. See how it looks like an orange peel?
Yes.
That's when you know you did it right, okay? And then we're going to be going in on the right side a little bit lower, just a little stick and burn. This is normal. When you go to the dentist gives you a little numbing medicine in your mouth. It's the same thing. It's not comfortable, and we try to keep him a little sleepy for it. You're doing great. That's just the numbing medicine going in. I injected 8 cc's. So on the left side, we're going to fix L3-4 and L4-5. On the right side, we're going to fix L4-5, L5-S1. Let me know if it's uncomfortable for you, and I can give you some more numbing medicine. All right, so we're going to start at the skin, and we're going to aim for the L3-4 disc and the L4-5 disc. All right, I need to see 5-1 as well, just to make sure I'm heading to the right target. It looks like I am. That's too much of 5-1. I need to go a little bit higher, a little more north. All right. Now, folks, no, come on, the other north. So, folks, we use a special X-ray machine to navigate and localize to the right disc. And this machine is called a fluoroscope. And it's a $150,000 X-ray machine. It has wheels, it's mobile and shot, and we use it to get down to the proper spot, which is the back of the disc shot, where the tear is located that's causing all of his back pain. Now he's got 4 tears causing his back pain. There's one at L3-4. Why don't you show our audience the L3-4 shot? All right, beautiful. Y'all see the L3-4 disc right there? Show them the front of the disc and the back of the disc. There's the front, there's the back. Show them the L3 vertebral body, the bone. There it is, that big bone right there. Show them the L4 vertebral body, yes. And you need a cushion between them because you got movement there. Give me an AP, or lateral view, I mean. All right, so we're in the foramen, shot. I'm heading towards that disc. I can feel the facet joint. And we're trying to navigate around it. Shot. Shot. Is he okay? Shot. Shot. How reliable are we? AP. Notice I'm low in the foramen again, as I pointed out before. Lay still. So, yeah, that's fine. Oh yeah, there's a lot of bone spur on that side. Let's go back to a lateral. You can see the tip of the needle is, show the audience, actually it's kind of not a great AP. He's got some scoliosis there. Show them the tip of the needle. Henry, on the x-ray?
Yes, sir.
There's the tip of the needle, and it's just about at the disc, so it's perfect positioning on the AP view. Let's go back to a shot, lateral. You're overexposed, good. All right, very nice. So we're heading towards the left L3-4. Everyone agree, left L3-4? Shot. Maybe a little bit lower than I want to be. Let's see. Just lay still. Shot. Yeah. Lay still. You're doing great. Everything's okay. So because our patients don't have a tube down their throat, we can't put them too deep. We need them slightly awake, helping us in the beginning of these surgeries, and then we'll put them more asleep later. Lay still. Shot. So I'm hitting just the top of that L4 vertebral body. Yeah, it's all on his back, I'm sure. Shot. Just don't move.
Stay still.
Shot.
Stay still. Keep your head down.
So what I'm doing is I'm pulling back a little bit with the needle and I'm redirecting to go north just a little bit. That's too much. So I want to come back. I want to go south just a little bit. Lay still.
Okay, good. Put your head, turn your head this way. Good. Perfect. That's perfect positioning for you.
Yeah. Shot. There we go. That's perfect right there. Lay still. Now, of course, he's not going to like this because this is one of his bad discs, right? So this is an uncomfortable area for us to be working in for him, okay? But I feel really good about that placement. We're inside through the tear on the left side at L3-4. Lay still. Let's give him a little more numbing medicine. So sometimes the skin numbing medicine can be very helpful. We want to also try to deliver it down into the soft tissues below. We call that infiltration. Lay still. Now, that's a 7mm incision. It's tiny. Everything's good. So we've placed the first needle, and now I'm going to place the second. The second needle is going to go to L4-5. Lay still. You're doing great. Shot. All right, now that L4-5 looks like we're off a lot on orbit, but, you know, help me out with that. I don't know that it's worse. I think it's better, but the problem is there's scoliosis there. Shot. Maybe a little bit better on the orbit if you can make it. Shot. Uh-huh. Is he reliable?
Are you feeling that down your leg or in your back? Sir, where are you feeling that, leg or back?
AP.
He says back.
All right, you're doing great. Lay still. Everything's okay. So because our patients are somewhat sleepy, we do talk to them in case they're coherent. We want to make sure they know everything's all right. So that looks good. We're about to enter the disc. Now, as soon as I get this needle in place at L4-5 through the left tear at the back of the disc, through the foramen, I'm going to then switch over to the right side and start working on the right side.
You're doing great. Doing great.
That's a big tear. That went in real easy. So huge tear, left side at L4-5. But we're now done with the left. We're going to go to the right.
You know, a little more numb, maybe?
I already put it. Yeah.
Alright.
Lay still.
Head down. You're doing really well. Just gonna let us know if you feel it down your leg or in your back. You let us know.
Hmm.
Doing well, my friend.
So his iliac crest is there. All right. Let's see. You're going to do 4-5 first? I think we need to do 5-1 first. Let's focus on L5-S1. So we're going to get 5-1 lined up. That's the L5-S1 disc with the fluoro machine first. Remember, the rule is you never navigate with a needle until you first get your X-ray picture set up properly. We're really off on the orbit. You got to change the orbit. That looks, it's definitely different. I'm not sure it's better, but let's keep going. Let's try a little more. He's just got scoliosis. That's the problem. Keep going. Let me see one more time. That actually looks better, I think, right? Yeah, that looks better. Yeah, okay. All right, let's give it a little more num-num. Thank you. So we're giving him some more numbing medicine. Try to make him a little more comfortable. You're fine. Everything's okay. And we broadcast these surgeries live, not to upset people, but because we want them to see just how amazing spine surgery can be. Shot? No. He's got a high iliac crest. I'm going to have to come a little more medial. Shot? And aim a little more south. Let me have some more num-num. Now, have you tried some dissociative anesthetic?
Not with him.
How come? Just thought he'd be easy?
No, I just he's breathing. Because yes, he mixed a lot of meds. Stay,
Hmm.
keep it simple technique.
Well, it's not simple for me. Shot? Shot? Huh?
After we're done needing to speak to him, give him some.
Shot? Close. Shot? So when I say shot, what I'm asking my team to do is to take an X-ray picture. Shot? And I'm aiming right for that foramen at L5-S1. AP? So we're a little bit off on the orbit. Why don't we get the orbit just a little bit better? Show them the back of the pedicle of L5. See how there's a double shadow at the back of the pedicle? Nope, that's the facet. Go to the pedicle, yeah. That's one, and then show them the other one. There's the other. No, do a line right. Yes, there. And then the other one is further back. There. So I want to get those two spots lined up. That way my orbit will be correct. It's just about a degree off. That looks really good right there, as a matter of fact. Now, see how that changes the position of the needle relative to the back of the disc? That's why it's important to get the alignment right with the fluoro and the spine first. Once you do that, you can have reliable information, navigational information. You can't just stick these needles wherever you want. You got to put them in the right spot. Okay, back to a lateral. That looks good. So on the AP, you're looking at the pedicle of 5. Show them the pedicle of 5 on the AP view. Henry, stay on the AP X-ray.
Copy.
Jordan's going to show you the pedicle of 5. Very nice. Now show them the pedicle of S1. It's a little harder to see. Nope, that's the foramen. Show them it's a little bit above that. Yes, it is. That's it. Circle that area a little bit higher. Yes, yes, that. Yes, it is. Perfect. So that's what we're looking for. Those two pedicles, we want to go between them. We want to draw a line between the middle of them, and that's where the disc starts. So we want to get a little closer to the disc. You can see we're off the disc there. Are you okay? You're doing great. Just lay still. We're going to have you asleep soon, okay? I need you awake in the beginning, though. Everything's going perfect. Okay, now we're at the back of the disc.
Having any leg pain or just back pain?
No, he's not going to have any leg. We're clear. Give me an AP. I'm going to show you guys the AP one more time. By the way, we've lost 2 drops of blood the whole surgery so far. We'll probably lose less than 1 milliliter. 1 milliliter is 20 drops of blood. We'll do another AP view. Now, show them the pedicle of 5, the pedicle of 1, pedicle of 5, pedicle of S1. Show them the line between the middle of the pedicles. That's it right there. And look where the needle is. That needle is exactly at the line in the middle of the pedicles. So we are right at the disc, and I can actually feel it with the tip of my needle. You're doing great. We're almost done, okay? We're going to put you to sleep soon, but I need you awake. Don't move around. You're doing really good. There's no issues. Everything's going smoothly so far. All right? We are inside the 5-1 disc. Now we're going to place our last needle, which is going to be the 4-5. I'm using my 11 blade. I always line up at the base of the needle. If you don't do that, what's going to happen is you're going to end up making an incision that doesn't include the needle. And then it's going to be really weird because it's not going to work. You're going to have to make a separate incision. So you always want to make sure you incorporate the needle shaft in your incision. All right, shot. We're going for 4-5 now. Shot. Shot. Perfect. So I'm going to loop around this facet. I'm going to sneak around the facet, entering the foramen. I'm in the foramen. I can feel it. Yep. So I just entered the foramen. I'm aiming for that 4-5 disc. And I can feel it. Now I feel like I'm on the back of the herniation right now. Okay? And I am. There it is. Are you okay? Yeah. You're doing great, by the way. Man, big tear. All right. We're going to put you to sleep in just a few minutes, okay? We've lost 3 drops of blood, folks. Let me tell you something. Before I did the endoscopic surgery, I did fusions. When I did a fusion for your problem, the incision on your back was from here to here. It's literally 10 inches. But today we're going to do your whole surgery with ½ an inch. And we're not going to remove any of your bones and ligaments. It's incredible.
I thought you were kidding.
Luis was just so absorbed. All right, why don't we show actually we're gonna need you guys here for just a minute. So are you comfortable? Yeah. All right. No pain? Now how long have you had back pain? We were talking about this earlier. We had about 5 years, is that right? Or longer?
I'm sorry? 2 years on the sciatic pain.
2 years with the sciatic, but what about back pain?
Back pain when you're back.
When did you first have back pain in your life? The first time?
I'm sorry? 20 plus years.
20 years. Oh, okay. So never mind. He's had back pain for 20 years. He's had sciatic pain for 2 years. Okay? So this is the problem. Why would this gentleman live with 20 years of back pain? Anybody know the answer? Because he didn't know about Deuk Spine Institute. That's why. We've been curing back pain for 16 years. So he would have had to live 4 years. Now, why did he start looking for help? Because his leg pain started 2 years ago. And when people get leg pain, sciatic pain, they go to the doctor, and that's when the doctors start taking them serious. But the whole 20 years of back pain, they just blew them off, probably. Okay? Because society tells people there's no way to fix back pain, so just live with it. Take pills, do shots, do therapy, do chiro, None of those things fix the problem. Are you comfortable? All right. How bad is that on a scale of 1 to 10? 10 being the worst pain. What's the highest it went? Really? 4? So it only went to a 4. Is that where you typically get your back pain?
No, when I get sciatic, it's like 12 out of 10.
He says 12 out of 10 when you get sciatica. It's not.
Ah,
Is that
but
where you get your pain though?
is that the location where you typically get back pain?
Down where I look like it.
Down the right button.
All right.
Yeah, like it. Into the ankle.
How bad is that on a scale of 1 to 10? Huh? Like 10. Is that where you typically get your back pain?
Yes.
All right. So the left L4-5, he said, was a 4 over 10 concordant. This is 10 over 10 concordant at 3-4. All right. Is that better?
Yes.
I'm sorry. Have you watched any of these surgeries before?
Right?
You have, right?
Okay.
You watched the videos in the past?
Yes.
Yes.
Can you help me?
Yeah, of course.
Mm-hmm. More. How bad is that on a scale of 1 to 10?
7
to 8.
8. We always go with a higher number. 8 over 10. Is that where you get back pain? All right. So we've got 3, 4, 10 out of 10. Left 4, 5, 4 out of 10. Right 5, 1, 8 out of 10. Oh, do we test the 4, 5? Oh, I want to test 4, 5. Yeah. Yeah. We're almost done. We're going to put you to sleep in just a minute. Hard. How bad is that on a scale of 1 to 10? 8 out of 10. Interesting. So I've never seen that before, where the patient has on one side of a disc 8 out of 10, on the other side of the disc 4 out of 10. That's the first time I've tested the same disc on each side. So that's pretty interesting. You get to go to sleep. When you wake up, that back pain that you've had for 20 years will be gone, okay? I want you to count from 1 to 100 in Japanese. You're going to Japan, so you got to be able to speak Japanese. Huh? All right. Very good. So, at this point, what? Yeah, no, it's good. He's got 4 needles because we're fixing 4 spots. 2 of those spots are at L4-5, one on the left, one on the right. And these spots we're fixing are actually annular tears with herniated disc material. Where are we starting, Luis? 4 or 5?
4 or 5.
All right, fair enough. So we're going to start at L4-5. We got our guide wire in, taking out the needle, and we're going to place our dilator. Now, for those of you who haven't seen the surgery before, this is endoscopic surgery. So, in the end, the entire surgery will be done through this very tube right here. It looks like a straw, like a shake straw. The way it works is I'm first going to place my dilator. You can see the tip of this is tapered, and this dilator runs down the guide wire that we have right here, and it's going to spread the tissues gently. And when I say spread, it's going to spread them open about 5 millimeters. Then we're going to pass this tube right over the back end of the dilator, and this tube is going to spread it to 7 millimeters. Okay? So it adds another millimeter on each side. And then I'm going to take the dilator out, and we're going to have just the tube. And the end of the tube, you'll see it, is going to be inside the annular tear and the herniation. And then we're going to remove the herniations, and we're going to clean the tear so that the disc will heal properly on its own. There's no need for metal or fusion. There's no need for artificial discs. But if this patient went anywhere else in the world, he'd be getting far more invasive surgery that's unnecessary. Now, we used to do fusions here at Deuk Spine. We still do. But we try not to because it's unnecessary for the most part when you have the endoscopic technology. Lay still. All right, so we're down here. Lay down. All right, so I'll just wait a minute, doctor, until you're ready for him. So all of our patients are put to sleep, but we can't put them completely out because they'll stop breathing. So we have to keep them awake enough to breathe. And if they don't breathe on their own, we have to stop the surgery and get them breathing and then restart. So we want to keep him comfortable, but not so deep that he's not breathing on his own. Take your time, guys. Take your time. Let's do it right. So at this point, we're going to use our X-ray machine to navigate. Now, Henry, why don't you show our audience, why do herniated discs in the lower back cause back pain? What's the mechanism? I can tell you it's inflammation inside the tear in the back of the disc, but watch this video and you'll see for yourself how it works.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. Now, you've had an opportunity to watch two of our videos. The first one shows you how a tear forms in the back wall of the disc, right where the pain nerves are, and how the herniation causes inflammation and pain. The patient perceives that pain as highly localized back pain, and that's what we're here to fix today. Then you saw how the endoscopic surgery uses a laser to clean out that tear. He's doing great right now. Is he okay? So we've got our patient nice and asleep. He's just cruising. We're going to go down now and take a look at this disc. I need that light moved because I'm inside the disc and there we go. I need that light moved. Not you, not you. Let her move it. There you go. That's all. They're fine. So that is the herniation fragments, the blue stuff, herniated fragments. It's kind of mushy because he's blown this thing out pretty good. A lot of people don't realize that herniations usually are like many herniations. It's not just one piece. Is he okay? Yep. Coughing? A little bit? You're welcome to lighten him up a little bit. Oh, he just bucked 3 times, so I figured it's coughing. All right. Well, we're inside the herniation with the laser now. The laser is the blue fiber you're seeing inside the middle of the tube. And for those of you who don't know, the fiber itself is around 1 millimeter side to side. The blue part is around 2 millimeters. We are in the L4-5 disc, correct, Luis? This is his worst disc structurally. And from a pain standpoint, the 3-4 is more painful. But the 4-5 is pinching the nerves in his legs, going down his legs. How are we doing, Doc? He's good? All right. Do we have any questions from our audience at this time?
No current questions, but we do have 3 comments. The first one comes from Just a Clown on YouTube. And they said, "This is so interesting."
Good.
XPX30s on YouTube said, "Good day, guys."
Thank you.
And we got we just got a question, but this comment comes from Zora on YouTube, and they said, "Thank you so much for streaming content like this. I learned so much when watching surgeries being done in real time."
That's awesome. Thank you guys for the comments, guys and gals. Really appreciate it. It means a lot. Yeah, we stream the content for several reasons. Number one, we want the world to know that there's better treatment out there and that you don't have to live in pain. It can be fixed. We also want you to know that there's treatments now that are better than what's being done by surgeons with metal, fusions and artificial discs. You don't need any of that done. But they're not going to let you see this kind of surgery because they're not making money because we're not putting metal in. By the way, that's the tear right there. The annular tear, and the blue stuff is the herniated disc that's inside the tear, causing all the problems for the patient. So we're going to vaporize the pieces of herniation, break them up, and get rid of them. And they're going to float out. Maybe you can see them floating past me. The reason they're floating is we have saline irrigation. It's cold. And the saline irrigation does 2 things. When I use the laser to break up this tissue into small pieces, it literally floats all the pieces out. And then it also cools the laser, because the laser can get very hot. It can melt steel, but we don't want it to get hot, so we don't want it damaging the tissues. We don't want to fire. So you have to submerge it in cold, basically salt water. It's very common to use this kind of salt water in surgery. We call it surgical irrigation. It's used in pretty much all surgeries. No matter what kind of surgery you're doing, we use irrigation. And you want it to be as similar to the plasma as possible physiologically, so you have the right electrolyte concentrations of potassium, sodium, calcium, magnesium, etc. And so we buy it prepackaged in bags, and it's sold. What do we pay for a bag of this stuff?
This one is like probably 30 bucks, 50 bucks.
$15 a bag, roughly. So you can see the tear right there, right in the middle. That is the annular tear. That is the left L4-5. You guys doing all right? All right. He's fine. He's not moving at all for me. He's doing great. So as long as you guys, you can lighten him up a little if you want. All right. Any questions from our audience, Henry?
Yes. This question comes from Michael H. on YouTube.
Hi, Michael.
And Michael said, "After clearing out the herniated disc, does the annular tear heal 100% so there won't be a reherniation? Also, how long does it take for the tear to heal?"
Michael H., you are awesome. I love the question. You are so intuitive. Yes, that's the whole point. By doing the debridement with the laser, the tear will heal naturally. The problem is no other doctor does this. So they don't let the tear heal. You see, if you don't do the debridement, which is removing all this junk, the tear will never heal, and that's why people keep getting herniations over and over again, bigger and bigger and bigger in their lifetime. That's why they keep getting those cycles of pain where it flares up and then gets better as it starts to heal a little bit, and then they re-injure it. because the tear can never heal on its own. It needs help. You know, it's like a tumor. You know, a tumor in a person is not going to go away on its own. You know, doctors have to go in and take it out a lot of times. There are some exceptions to that, but the herniation itself will never go away. The tear will never go away on its own. It just keeps hurting the whole life. This patient's had 20 years of pain in his back, and it gets worse. You just keep pushing out more pieces, and eventually your whole disc goes away. You get a degenerated disc because you keep herniating. So when you do this surgery, it takes 1 year, 12 months, for that tear to completely heal solid. And when it does, then you don't have anything to worry about. You can go back to a normal life doing whatever you want to do. The reason it takes so long to heal is that the disc itself doesn't have much blood supply. It's avascular, relatively avascular. All right, we're just about done with this first tear. Again, this is a left L4-5. You can see the end plate of the vertebral body of L4 on the left. That's another piece of herniation I'm releasing and getting rid of with the laser. Right there. There it goes. Goodbye. Goodbye, and as they say, good riddance. One of the nice things about these live streams are that we can answer your questions while you're watching the surgery. I came up with the idea of the live stream broadcast years and years ago. We started 9 years ago. All of our surgeries have been live streamed here at Deuk Spine. And we use it as an educational opportunity because the viewers like you want to ask questions. So the reason I did this was that if you go and look at how our spine surgeons actually trained, we're trained the same way you're doing right now. We come and watch the surgery in the operating room. We get to ask questions. And that's what we're giving you guys the opportunity to do. We're giving you the opportunity to be a spine surgeon for a day, and you get to see everything we see. I can't let you do the surgery, obviously, but you get to participate pretty well and ask questions. So I thought it would be a great opportunity to teach, and it has been. Had thousands and thousands of people watching these surgeries over the years. If you go back to our YouTube site, if you go to the YouTube channel and go to Deuk Spine Institute's channel, you can actually watch the fusion surgeries I did over the years. Lumbar fusion, cervical fusion, ACDF, PCDF, thoracic fusions, even some peripheral nerve decompression like carpal tunnel surgery, ulnar nerve release. So any kind of surgery we do here, you can watch on our channel. And we have 9 years of surgeries, thousands of surgeries. All right, next question.
Next question comes from Saad Dalip and they asked, Saad Dalip on YouTube, and they asked, is holmium laser or NIDIAG laser straight firing or side firing, 80 or 100 watts?
Yeah, this is a holmium YAG laser, and it's manufactured by Luminous. Luminous is an Israeli company, and they produce great lasers, medical lasers. So it's a holmium YAG laser, and I use a straight firing. So side firing is unnecessary. Great question, because there is a side firing fiber. The side firing fiber is very expensive. It just adds more cost, and it's unnecessary. The straight firing fiber I've used since the very beginning, 16 years ago when I started, and we've never had a problem using the straight firing fiber. The only modification, we have used side firing, by the way, many times, but the side firing doesn't work as well as the straight firing. And the side firing starts to lose its power through the surgery. You know, for some reason, just because the little mirror that reflects the laser energy actually takes a beating from the laser itself, the energy. and it stops working properly. All right. Great questions from our audience.
We have another question.
Sure.
This comes from Daniel Garcia on YouTube.
Hi, Daniel. Welcome to our live stream.
Daniel asked, if you have 2 herniated discs, do you have to go in 2 different spots, or you reach both discs through the same entry?
Yeah, great question. So we can use the same skin incision. So if you look at your back afterwards, you'll have 1 cut, but we have to go to 2 different discs. So once we get inside your body, we're going to have divergent path. One goes to one disc and one goes to the other, but you'll never see that. Your skin will show 1 cut, 1 incision, 1 entry point. Great question. As a matter of fact, we're going to fix 2 discs on each side for this particular patient. And each disc will be fixed with 1 incision in the skin. Next question. See the blood vessels right there, the little veins? I'm going to try my best not to do anything with them, but if they get in my way, I'm going to have to sacrifice them. We call it sacrificing in surgery.
Next question comes from Janice Powell on Facebook.
Hi, Janice.
And Janice asks, besides money, why will other doctors not get on board to do this technique to just help people?
Janice, I agree with you. You're frustrated. Look, it's not just money for the doctors. It's really, they're not even being exposed to this. They have no idea it exists. And the reason they're being hidden. It's being hidden from them. They're not even aware this technology exists. And the reason is their education in training is controlled by a chairman. A chairman is the boss. The chairman decides what surgeries are done and how they're done. And the doctors in training never decide. They're always told what to do by the chairman. So the chairman, unfortunately, I'm going to tell you something that's going to bother you. The chairman of big universities are paid off to the tune of millions by companies like Deuk, Medtronic, the ones that make the screws and rods for fusions and artificial discs. They're paid off. They get millions and millions of dollars a year in support. And in exchange for that money, they keep the residents doing the fusion surgeries and the artificial disc surgeries. They don't let them learn this type of surgery. It's kept from them. It's an understanding, you know. It's what is the word? The group of people who do things a certain way and they won't change what they do because they have power and control and they're getting a lot of money for it.
Elite?
Huh?
Elite?
No, it's I can't remember. If you watch the movie Dune, the original movie Dune, the people who control the spice. Huh?
The Fremen.
No, not the Fremen, but the people who mine it on the planet. Ultimately, the Fremen, right? They're the native inhabitants, but the guild is what's called a guild.
Oh.
Yeah, the guild.
Okay.
So the guild is a group of people who control an economy, a microeconomy, and they do it their way. They teach it and they keep it that way, and they don't deviate because they maintain ultimate control and money and power. And that's what's happening. There's a guild, basically. Huh? We do? Yeah, so there's a guild of spine surgeons, and the implant companies control those guilds, and the leaders of the guild are paid off quite handsomely so that they keep the new surgeons from learning anything other than the fusions, because what they're doing is they're investing in the future. These implant companies, they put in the screws and rods, they manufacture the screws and rods, the surgeons put them in. So during the training, they want the surgeons putting their screws and rods and cages in. Every one of these fusion surgeries make the guild $10,000 to $50,000 in just metal I mean, even 100,000 in some cases. So multiply that times 1 million surgeries done in the United States for fusion every year. So 1 million, now it's up to 2 million fusions of the spine every year. 2 million times, say an average of $10,000 is conservative. That's how much money is being made for spinal implants in the United States alone. I don't know what the math is. I need someone to multiply 10,000 times 2 million to give you the number. We're done.
We're good? All right.
Yeah.
Lights on, please.
His nerve going down his leg is in that fat right there. It's protected. Actually, let me see that for 1 second. Just a little bit left. How much is that?
20 billion.
No, 200 million, right? Which is it, 20 million or 200 million? 10,000 times 2 million.
I got 20 billion.
It's far more than 20 million. Anyway, I can't do the math right now, but long story short, it's a large sum of money being spent on spinal implants every year. And those companies that make that, by the way, we need a real number. Somebody do the math. 10,000 times 2 million.
I got 20 billion.
20 billion?
Yeah.
I thought you said 20 million.
No.
I'm like, no, I think it's more than that. $20 billion, guys. So that's how much money is being spent on metal implants. $20 billion a year. Okay? And guess what? If all the surgeons did this surgery, that 20 billion would go down to about 20 million. So those companies will go broke. Now, do you think they're just going to say, oh, this endoscopic surgery is better for patients? Let's just throw away our business model? Hell no. They're going to protect it. They don't care what's best for patients. They care what's best for them. They're a business. So wake up. I'm sorry I can't fix corruption and greed, but I certainly can fix back pain. Lay still. All right. I hope that, Ms. Powell, I hope you understand my answer. It is the God's honest truth. I stand to benefit nothing from telling you the truth, but you do. You people that suffer, that don't want such invasive surgeries, you all want to be fixed the right way, less invasive. Well, you're going to have to advocate for yourselves. I can't fix the broken healthcare system myself. I can just make you people aware of what's happening. And then you guys have to decide if it's worth it for you to fix it. But you're going to have to fix it yourselves. Great question, though. All right, next one. Take a shot. So we've just finished fixing L4-5, left side. And now we're going to go to L3-4. Shot? So I'm going to take the spinal needle out, but I'm going to leave the guide wire. The guide wire will guide my dilator, this instrument, down through the muscle and into the disc, the tear of the disc, the herniation in the back. Nope. How's he doing? I wonder if there's some stuff in there. There is. That's why. All right. So, any questions? Shot?
Yes, we have a couple of questions. This
Shot?
first one comes from Doreen on Facebook.
Hi, Doreen. Welcome.
And they ask, hi, Dr. Deuk. Is it possible to decompress the nerve roots from the lower L4 to S1, etc., to stop the weakness numbing?
Yes. Yeah, great question, Doreen. 100%. We're literally going in right where the nerves get pinched. Those things are nerve roots, as you pointed out, and that's where we are. We're literally just underneath the nerve root and just lateral to the traversing root. And one of the things this surgery does is it decompresses the nerve roots. Shot? But unlike other types of surgery that just stop at decompressing the nerve roots, like laminectomy and microdiscectomy, this surgery actually cleans the tear. Yep. from whence the herniation comes out of and allows the disc to heal naturally. It also gets rid of back pain. So we decompress nerve roots. We naturally heal and allow the disc to repair itself by cleaning out the tear. You're doing great. And we eliminate the back pain coming from this disc. All right, done. So we have a little bit of cold welding going on. What cold welding means is that a little bit of the herniated material is stuck between the dilator and the tube. So it kind of makes the two stick together. And Luis just wiggled it out nicely. We're ready now to fix the L3-4. Our patient's doing quite well. He's asleep. And your questions are wonderful. Keep them coming. Feel free to ask me any question you want. Just don't ask about anything other than spine. I don't talk about politics and other stuff. We'll talk about movies every once in a while. But keep them on topic and we're good.
We have 2 questions. Both come from Sai Dalip on YouTube.
Hello. Nice to have you join us.
First question is, how many watts does a laser machine have?
Yeah, I'm sorry. I forgot to mention that. Correct. So this Homeomyag laser is 100 watts. 100 watts. And we're using it at around 60? 52.5. So 53. We're using it at 53.
And the next question is, as a spine surgeon, I do interlaminar endoscopic surgery. Can I use the same laser for annular repairs as well?
Yeah, nice to meet you. It's good to hear from another spine surgeon. Are you using an endoscope currently?
They said interlaminar endoscope. That's
Yeah, okay. Yeah. So he's doing the unilateral biportal endoscopic procedure. It's very popular over in India and Asia. And you can use this laser, but you're going to have a hard time because when you go through the lamina, when you go translaminar, basically you're going to end up with the thecal sac in front of you. You're going to have to take the nerve roots and go lateral and retract that nerve root, the traversing root, lateral. I'm sorry, medial, not lateral. You're going to have to go lateral to the root. And you can use the laser. I've never done it with that approach. I think this is a much better approach. Hey, we need the laser. So you should be able to use this laser though.
He said yes, both transforaminal and stenosis monoportal scopes. Monoportal scopes.
Yeah, understood. I'm familiar with the UBE procedure.
No current questions, but we do have a comment from Doreen. From her question, she says, "Thank you. It brings me so much. It brings me so much hope to walk better and ride a bike again."
You're welcome, Doreen. That's why we do the broadcast. There's what I found over the years to be so much misinformation when it comes to back pain, neck pain, sciatica. People are not being told the truth. And this is a worldwide phenomenon because doctors just don't know the answers for the most part, or they don't want to know the answers. They want to continue to do what they're doing now because it makes good money for them. And the patient is the one who suffers. Why? I guess I just have a little bit of end plate bleeding. So the visibility is not great. I apologize. This is because we have some bleeding from the end plate. Now the end plate is the surface of the bone adjacent to the disc, and you typically will get end plate bleeding. There it is right there. That's end plate bleeding. Because of arthritis, in the disc, and it's representative of something called degenerative disc disease. Degenerative disc disease is inflammation within the disc that affects the end plates. Ultimately, we call it spondylosis, and you get an inflammation, which, of course, as you know, inflammation brings blood supply, increased blood supply. All inflammation is characterized by redness, swelling, pain, and increased temperature. And that's because there's more blood supply to the inflamed area of your body. So this patient has inflammation going on in his disc, and I'm trying to get rid of it by eliminating the source of the inflammation, which is the herniated disc within the annular tear. Great question so far from our audience. Why don't we show our audience a comparison between the Deuk laser disc repair and an alternative procedure that would be considered very useful for treating back pain from a herniated disc or degenerated disc, called transforaminal lumbar interbody fusion, TLIF.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
Welcome back. We have just finished, the 2 disc repairs on the left side, L3-4, which was a 10 out of 10 pain disc, and L4-5 on the left, which was a 4 out of 10 pain disc. We're moving over to the right side, which is the L4-5, L5-S1. Remember, this patient's having 4 areas fixed, okay? And I think he's going to do fantastic after this surgery. I'm really excited for him. Huh? Where do you want the num-num? No, put some num-num.
You want locally?
Where is the typical num-num? No, the deep num-num. Yeah. We're going to give him a little more numbing medicine. All right, so welcome back. Let's show them the incision. here's the incision, folks. That's my finger, just to give you an idea. Look how tiny that is. That's about 8 millimeters. You can see pieces of herniation right here. You see this, Henry? There's a piece. But they're all over the place. Can you see these?
Yes.
They floated out during the procedure. We don't collect all of them because it's impossible because, well, I mean, I guess you could buy special traps, tissue traps and things. But here's just an example of 3 pieces of herniation that came out. And there's literally, they're all over the place. But as long as they're not inside, that's good. We want them outside. All right, we're going to keep going. We're starting with the L5-S1. Let's see, shot. All right, Luis, you got this? Probably just another minute. And the only reason we're holding pressure on the muscle is muscles can bleed. If you get a little vein that's caught during the procedure, it can bleed a little bit. So we don't see any bleeding. We've literally lost maybe 5 drops, 10 drops of blood at most. Even the bleeding off the end plate that you saw was just little wisps. Really nothing significant. Shot? All right, so we are right at the back of the L5-S1 disc. I can feel the tear. I want to pull my guide wire back a little bit. Shot. I'm going to pull it back a little more. I don't want it getting trapped by the dilator and then pushing into the pelvis. You don't want that going into the pelvis. The pelvis is where you have all kinds of things like intestines and other things. Bladder. Shot. Okay. And a sharp wire can poke at things. We don't want that. So we're entering the L5-S1. Go. L5-S1 disc. Perfect. Now the tube goes over. After this disc, we have one more to go. Shot. That's it. Done. All right. We're going to take the dilator out. His spine is deeper than I thought it would be. He's actually a very thin person, very, very good shape. But it has nothing to do with how heavy you are, how much weight you have on you. The spine itself can either be right next to the skin or it can be really far forward. In his case, his is forward quite a bit. And it's just natural variation. Some people have a spine more forward than others. And it makes it harder for me when it's more forward. So just be aware of that. That's something nobody ever talks about. But I noticed it when I was doing my fusion surgeries. All right.
Lights out, please. Thank you.
So the dye is already pretty much gone. A little bit left. This is pieces of herniation. They're pretty scarred up, meaning they've been there for a while. If I had to guess, I would say the L5-S1 disc has probably been a problem for him for, out of the 20 years he's had back pain, probably at least 19 out of 20. This is definitely an older injury. It's very fibrous.
Yeah, it's
Very
dry,
fibrous. Yeah, you feel it too.
Yeah.
Yeah, you can tell because, and this is something I tell all the attorneys that, you know, they don't have a way to know how old a disc injury is, but endoscopic surgery is a great way to figure that out because we get to actually play with the disc inside the disc.
We have a comment and 2 questions.
Sure.
The first comment comes from Sai Dalip on YouTube, and they said, "Thank you, sir. It's been a pleasure to see your surgery with such an ease."
Thank you. I appreciate the compliment. You're always welcome to come and join us, and I'm happy to answer whatever questions I can for you. These surgeries are for everyone, surgeons, patients, healthcare providers, administrators, anyone that wants to learn the truth about spine care in the world and where we are, what we're capable of doing. I think what you're seeing is the most advanced in the world, and you know, we're going to continue to broadcast what we do. If you watch my YouTube videos, you can see that I do all types of surgery. I don't do the UBE procedure because I don't think it's necessary and I don't think it's helpful. It's certainly not better than what we're doing here. So someday maybe you'll incorporate our technology and technique into your practice. Thank you for your comments.
We have so far 3 questions. This first one comes from Michael H. on YouTube. And they asked, how reliable is the laser? Has it ever failed or malfunctioned while performing surgery?
That's a great question. So how reliable is the laser? Has it ever failed or malfunctioned during surgery? The answer is no. It's never malfunctioned in such a way that would cause harm to the patient. Now, of course, like any machine, it can stop working. Maybe the pedal might break, or the glass itself might break, in which case we have to strip it down. But it's never caused harm to a patient, ever. Honestly, it's a $120,000 machine. 120,000 US dollar, 120,000 euro, however you want to say it. It's a very, very well-built, well-designed machine. Very safe, very reliable. We love this machine. We have one, only one, because they're expensive. And someday I'd like to have a second one in case this one breaks as a backup. But the reality is they're very expensive, so it's not easy to have more than one. That said, we've not had a problem with the laser, but you're right, it could happen. So what is our current backup plan? If the laser fails, there's companies in the United States that will rent you a laser on a moment's notice. They own the laser. We own this laser, but they have lasers themselves, and we can rent the laser for the day. So that's our current backup plan should this laser fail. But the laser is extremely safe. There's only been one patient that I know of that was harmed by this laser. One person that was harmed by this laser. And that was me. When I was first learning the technique using the laser, I was twisting the fiber in my fingers like I do to get to a herniation piece, and I broke the fiber in my hand. And when I did, the laser went into my finger and burned me all the way through, almost my entire finger. It was very painful, but I still have a scar today on my index finger on my right hand. But I'm the only person that's ever been harmed by the laser, and it's because of the way I handled the fiber. I didn't handle it properly, and I was too aggressive with it, you know, trying to ask it to do something it can't do. And I paid the price, but I don't care. You know, we all make sacrifices in the pursuit of excellence in life. If you want to be the best at something, you're going to have to accept at some point that you're going to have an outcome that maybe you don't want or that's harmful to you as a scientist, as the doctor. That's part of being a good doctor, you know. Remember, those doctors that figured out that urine tastes like is sweet in a diabetic patient, they had to drink the urine. They had to drink the diabetic patient's pee to realize that they were peeing sugar out of their body. At least I don't have to drink pee. So I am grateful about that. I'd take a laser blast to the finger any day. You guys doing all right? All right, just about done here. This is a very, look at that. Look at the inflammation. You guys see it? The pink, that is inflammatory tissue. And this is an annular tear. It's very old. See how thick the scar tissue is, guys and gals?
Yep.
All that is scar tissue from chronic inflammation. And the pink stuff is granulation tissue. It's new scar tissue. New granulation, new inflammation. So whenever you see granulation tissue, it tells you there's active inflammation going on. whenever you see white scar tissue, it tells you there's old inflammation. This is all scar tissue here from inflammation. And this is the herniation, the blue, degenerated disc. All right, we've had a really good questions this surgery. We're almost done. This patient definitely needed the surgery. There's no doubt about it. He's going to be very happy, I think, with the results. I actually told him he may have some facet joint pain, which may need to be treated at some point, because that wasn't part of our surgical plan today. But when I saw him in the office, I noticed, lay still, that there was some facet tenderness. And I told him we may fix your discs first, and then you come back someday and get your facet joints treated. But this should take care of the vast majority of your pain, if not all of it. So I think he's, this disc or the whole surgery? 3 minutes. Want me to stop? Yeah, you know why this disc may not have anesthetized as well? It's so much scar tissue. So the medication can't diffuse into where the little nerves are as well, because it's so thick with scar tissue that doesn't have, mature scar tissue that doesn't have nerves. Tell me when to proceed. I need 30 seconds on this one. I think that's good. Take that. Let's see. Any questions for me?
Yes, we have 2 questions that come from Valen on YouTube. Forgive me if I pronounce that wrong, but their questions are, the first one being, do you use interlaminar approach? If yes, which indications do you use it for?
Oh, all right, Valen. Thank you for asking questions. We are not using the interlaminar approach. This is a transforaminal approach. This is far better than an interlaminar approach. The interlaminar approach, as you know, requires the removal of the lamina and facet and ligament, bone, normal structures. We're not removing any normal structures. We're using a transforaminal approach. We're using Cambin's approach, Parvis Cambin. All right, that should be good. How are you guys doing? Good? Can I go a little bit more? Just one more minute. Let me just get this one corner right here, and I think we're done. I think we're okay now, but I just want to make sure. So have I done the interlaminar approach? If that's the question, the answer is yes, many times. I've done the interlaminar, translaminar, laminectomy, microdiscectomy. As a neurosurgeon who was trained in 97 to 2004, I've done pretty much every kind of spine surgery there is. I went to a top training program in the United States, so I had exposure to trauma, tumor, infection, degenerative, and did surgeries of all types, cervical, thoracic, lumbar, sacral. So I'm capable of doing any type of spine surgery, but I choose to do this because it's the very best. It has the best outcome and it's the least invasive. I don't do any more interlaminar or translaminar surgeries because they're very destructive and unnecessary. You never need to do them, never. This surgery right here can be used in all cases where you're doing interlaminar, translaminar, laminectomy, whatever. Doesn't matter. Artificial disc, fusion, for degenerative conditions. The only type of procedure, the only time you should not do this is synovial cyst. Of course, because it's really hard to get the synovial cyst unless you start drilling away some of the facet joint, which I don't like to do. because it destabilizes the spine. If I'm going to take a synovial cyst out, I'll just do like a microdiscectomy approach, hemilaminectomy, partial facetectomy, and then synovial cystectomy. Before you do that, let's put some more numbing medicine in there. You have any more? What's the one with the concentration closest to what we put in the discogram?
So this one right here.
That one?
Yeah.
Not the
You
skin
want
one.
that or- No, this is the inside one.
Okay.
You want this one?
Yeah.
A little bit?
Go ahead and inject a couple of cc's. We're going to give him a little more numbing medicine into the disc itself, just so that it's not as painful for him. That's good. Right? You felt it?
I found it.
Luis has been my assistant here for years. He's the best assistant I could ever ask for. Better than Dr. Patel. But I'm sure Dr. Patel tells you that you're better than me. That's okay. All right, we've had some great questions. We're on our last disc. This is the L4-5 right approach. Remember, when we tested this with the discogram earlier, it was an 8/10 pain. You guys ready? All right, let's get started. I'm going to take the needle out, leaving the guide wire shot. You always want to check your x-ray as you're doing this because you might accidentally pull the guide wire out. If you do, you have to start over with the patient awake. You have to put the needle back in with the patient awake. You never want to accidentally injure the nerve root. That would be very bad. I've never injured the nerve root with this surgery. I did have 2 patients in 16 years that had a nerve that actually split in the foramen, and there were 2 branches exiting the foramen, and I could see them. And I've actually stretched that nerve in that case because there's no other way to do it. How's he doing? Is he okay? Okay. Here you go. Anyway, so instead of the nerve root coming out like this, his split, and we went right between it to do the surgery. I had 2 of those patients in 800 surgeries. Yep. All right. Sometimes people cough a little bit when they're asleep and they move. That's fine. Any questions from our audience?
Yes, this
Sean?
next question comes from Valen on YouTube once more. I believe you answered the question without knowing, but I'll ask it anyways. It's do you remove ligamentous structures on this approach?
So do we remove osteoligamentous structures? The answer is no. We do not. We don't remove anything, maybe a little bit of the foraminal ligament, which is the lateral extension of the inner spine of the ligamentum flavum. So if you think about the ligamentum flavum, it runs between the lamina, and laterally it becomes what's called the foraminal ligament. There may be a little bit of the foraminal ligament removed, but this is really a procedure that's done inside the disc itself and not really the foramen and not the central canal. We're operating inside the disc. We are literally inside the herniation. And this is called the inside-out technique. It was taught to me by Dr. Anthony Young in Phoenix, who is one of the pioneers in the world. He learned from Parvis Kambin. And we start within the disc, and we work our way out to the foramen, to the outer surface of the disc. When I get to the foramen, I stop. There's nothing in the foramen that I need to treat, except for the herniation. So all this laminectomy, foraminotomy, totally unnecessary, doesn't help with the back pain ever, only can help with leg symptoms from radiculopathy. But the truth is, my friend, I'll tell you a secret, since you're asking so many questions. This is the most important thing I'll teach you today. Think about radiculopathy. There's 4 symptoms that radiculopathy causes. Do you know what they are? I'll tell them just to be brief. Pain, called sciatic pain. Numbness, weakness, and tingling, paresthesias. Okay? So pain, numbness, tingling, weakness. 4 symptoms that are possible from the nerve root. What do you think is responsible for those symptoms? I'll give you 2 choices. One is mechanical compression from stenosis. The other is inflammatory irritation of the nerve root. Now, most spine surgeons are taught that it's mechanical compression, pressure on the nerve root. That's what I was taught as a neurosurgeon. But what I learned later in life from treating my patients and successfully treating them was that 98% of radicular symptoms do not come from compression, they come from chemical irritation. Chemical irritation. That is an important thing to remember. That is why so many patients come to your clinic, they have small herniated discs, disc bulge, but they have radicular symptom because it's not compression. It's not dynamic compression. You see, when I saw radicular symptoms in my patients with a small herniation that was not making contact with the nerve, I started to believe there was a dynamic herniation that was coming and putting pressure on the nerve when they were standing and bending. But it's not true, because these people have radicular symptoms even when laying down resting. And the reason they have the symptoms is not compression, it's inflammatory, irritation of the nerve root, the dorsal root ganglion, as a matter of fact, the dural sac over it. So, if you've learned that from me today, you've learned the most important thing I'll teach you today, which means do not look for a large herniation to cause radicular symptoms, because you won't find it most of the time. That doesn't mean the patient is not suffering. The patient is suffering, but they're suffering not from compression, but from an inflammatory problem. Where do you think that inflammation comes from? The answer is the annular tear and the facet. Mostly the annular tear. So what does this surgery do? We treat the annular tear. That is why we're so successful at treating not just back pain, but radicular symptoms as well. More successful than any surgery in the world. That's why people with microdiscectomy, laminectomy, they come to me with back pain or leg pain, and we fix them with this surgery. Even when we don't do a laminectomy or discectomy, we still eliminate the leg symptoms and the back symptoms. Okay? As long as it's coming from the disc, we can eliminate it, which is 85% of the time. Degenerative spine problems are inflammatory. They're not compressive. The compressive conditions are obvious, and they need decompression. But the rest of the time, they need a debridement, not a decompression. And that's what the Deuk laser disc repair is. We pioneered this treatment here. We're the first to publish it in the world, in the peer-reviewed literature. We published this in 2012, 10 years ago. You can read our papers. I've given up on the scientific community. That's why you don't know my name. I don't travel to the meetings and try to impress people with my name. I focus on my patients and making them better. There's a group of surgeons like me. We don't care about the politics and the academic politics. We care about fixing people's problems. That's why we went into medicine. And that's what our focus at Deuk Spine is, curing pain. We're very successful. Let's go ahead and run the video, Henry, showing how does a herniated disc cause back pain and leg symptoms.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. Hopefully you've seen now why an annular tear and herniated disc cause so much pain. It's not due to compression, it's due to inflammation. That video was created here at Deuk Spine based on our experience and what we've observed in our patients over the years. All right, I'm going to have you watch one more video and then I'm going to take your questions in a little while. I have to go wrap this surgery up. I'm going to see the next patient. We have one more surgery. It's a 2-level lumbar Deuk laser disc repair. And this was a 4-level, just so you have a reference point. We fixed 4 areas. The next one is 2 areas. But just about done. And our patient really wants to wake up and get off of this table. He's a very fit man, great shape, but he's been a challenge for the anesthesiologist and the team in terms of keeping him comfortable, but at the same time safe. And we've done a great job, and I applaud my team. Great job, guys and gals. Let's go ahead and run that video.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, A cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
It's Dr. Arjugmajan at the Deuk Spine Institute here in Florida with one of my patients who had the Deuk laser disc repair for a back injury, and it was around 6 to 8 weeks ago. And you're back for a checkup. How are you feeling today?
I feel wonderful. I feel great. I feel fantastic. I mean, this is the man. He's the man.
Well,
and I came in with a lot of pain. I couldn't believe it. And now I'm virtually pain-free. It's unbelievable.
How long did you have your back pain? How did that start?
Oh God, that happened many years ago at work, at least 20 plus years. And I had other surgeries in the past, and they really didn't help. And this last one, it just got so bad that I had to do something. So luckily, through the grace of God, I came here, and
Amen.
Yeah, and I'm A1 now.
Awesome. So you had your surgery. You've been doing therapy. Would you say the pain you had in your back before surgery is still there, or is it gone?
Oh, it's gone. It's gone. I have little twinges now, but they're muscular, and which is fine. That's going to go away over time. But my God, what a relief! I'm ready to get back out there and do all the things I used to do, man. It's kind of exciting. It's kind of fun.
Well, it's important that people understand too. When you have 20 years of chronic debilitating back pain, what happens is the muscles in your back shrivel up and atrophy because you're really not active anymore because it hurts too much. So, you know, we can fix the spine pain, but it's going to take time to rehabilitate the muscles and get them back to normal. So I'm glad we're touching on that. So what does your life look like now that we've gotten rid of your back and leg pain?
Well, I'm going to go back to what I've always done and what I've always enjoyed doing, which is my automotive hobby. And I'm really looking forward to being able to actually lift things again and getting the contorted angles that I used to get working under cars and stuff. It's just gonna be nice. Quality of life is it's
not too soon with any of that lifting engines.
All right, yeah, all right. But I have, all kidding aside, I have noticed over the years I developed a way to walk, almost a crab walk kind of thing, and I got used to it, and I got, well, that's the way it's going to be. I don't have that now. I mean, it took a little while because it was some pain trying to get the muscles to come back. But my God, you just stick with it. If you got to get it done, stick with it, because you're going to get better. You're going to get better.
Well, yeah. Congratulations. Is there anything you want to say to wrap things up to your audience?
He's the man. Come see this guy.
All right, congratulations.
Thank you, doctor.
You're
God
welcome,
bless.
Sir. God bless you.
One.
All right, well, I hope you enjoyed our videos and the surgery we've just completed on a patient who's traveled here from Canada. We literally fixed 4 areas of his back, 3 discs, but one of the discs had a tear on the left side. That was the L3-4 disc. And just to orient you, here's a model of the spine. It's not one of my patient's spines, but this is just made out of plastic. We've got the sacrum, the L5, the L4, 3, 2, 1. And today we did surgery on the L3-4 disc, the L4-5 disc, the L5-S1 disc. Now, he had a herniation on the right side at L5-S1, right in there. He had a herniation on the right side at 4-5. He had a herniation on the left side at 4-5 and the left side at 3-4. So we did a 1, 2, 3, 4 Deuk laser disc repair on this patient. And before we got started, the first thing I did was place the needles into the foramen. And just to give you an idea what that involves, here's the spine. And by the way, I mentioned it, if here's his skin, your spine can either be close to the skin or deep. And the farther the spine gets away from your back, the harder it is to do surgery. So, and that's all surgery, but a lot of surgeons don't talk about that. Be worth looking at sometime. Anyway, because the spine was forward, we came from the side, and I went transforaminal and got into the disc with the needle, and then we put all the instruments down that way, and we repaired the annular tear and got rid of the herniations. Surgery was successful. We had no complications. We quite literally lost, I put 2 milliliters of blood, but we really lost probably 1 milliliter of blood. 1 milliliter is 20 drops. I'd say we lost somewhere around 1 to 2 mils. That's nothing. When people do open spine surgeries, laminectomies, and microdiscectomies and fusions, the surgeon loses 500 milliliters, 1,000 milliliters. Sometimes if they're a really bad surgeon or get really unlucky, 2,000 milliliters. We lost 1 milliliter. So no blood loss with these surgeries. There's really no need for post-operative pain medication, so we don't give it. Our patients will take Tylenol, and they'll take a muscle relaxer called Robaxin. Robaxin works well for most patients, but once in a while we get a patient who it doesn't do anything for. I had a patient who was taking literally 5 times the allowed dose of Robaxin for 2 years before their surgery, and they were taking it in Canada. We didn't know it was Robaxin. It was a different name. And so when they came here, we gave them the 1 pill of Robaxin every 8 hours, and it did nothing for them. So they had built up a tolerance. So it's real important before you have spine surgery, try to cut back on your medications for a few weeks. Use them sparingly. That way your body gets a little more sensitive to them, so you respond with lower doses after surgery. That said, the surgery went perfect. Couldn't have gone better. Our patient was difficult from an anesthesia standpoint. From a surgery standpoint, he was, not too difficult. I've had much harder cases. So there's always 2 doctors caring for a patient in surgery. There's the anesthesiologist, there's the surgeon. The anesthesiologist said he was on a scale of 1 to 10, he was a 10. From my standpoint, he was a 5 in terms of difficulty. I've had 10s and I've had 11s. So I felt quite blessed that the surgery went pretty straightforward from a surgery standpoint. If you go back and watch the video, you'll see that we were able to clean out the tears with the laser, get rid of the herniations. I know we have a lot of questions, so without further ado, I'll get to them.
Alrighty. The first one was a comment, and this comes from Janice Powell on Facebook, and they said, "Doctor, you certainly show and tell the truth of these surgeries. It's so appreciated."
Thank you, Ms. Powell. I wish I had only good news to share with you all, but the truth is that I believe that human beings can do great things when they are motivated by truth. And my job is to tell you the truth. There's lots of people out there lying to you. I will not lie. I don't see a value or benefit in it. I've done quite well in my career. I could retire now very happily, and the only thing that keeps me going is that I like to get people out of pain. That's the truth. And I hate to see our great country's healthcare system being destroyed by corruption and greed from the insurance companies and from the companies that control the spine world with metal and implants. And unfortunately, the truth is doctors are really the ones that are the most responsible for allowing it to happen. Doctors should just say no. Take a lesson out of the page of history from Nancy Reagan and Ronald Reagan, 2 of the greatest presidents our country has ever had. 2 of the greatest people our country has ever had. Now, that was a Freudian slip if there ever was one. Nancy Reagan certainly was wearing some of the pants in the presidency. For those of you who knew Ronald Reagan and Nancy Reagan, she was outspoken, brilliant woman, highly respected around the world. Unfortunately, our leaders today are not so greatly respected. That said, the truth is important for people to know, and I feel blessed that I'm in a position I can share that with you.
All right, the next question comes from Doreen on Facebook, and they ask, what is facet joint pain and where is it?
Hey, great question, Doreen. So we have one of our viewers, Doreen, who's on Facebook, who's asking, you talk about facet joints, what are you talking about? So here, let me show you what I'm talking about, okay? The spine is amazing. It's really simple and yet so complex. The bones of the spine, called vertebrae, stack on top of each other, and they're able to move. And I want you to look. They can move side to side. They can move front to back. We call that flexion extension, lateral bending. And they can also do something called rotation. Not a lot of it, where they can twist side to side. You see that? So the spine is able to move in all three axes of rotation. Now, to move like that, you need joints between the bones. So a joint is any space between bones where movement occurs. The first joint is the disc. That's the biggest. It's obvious. Everyone talks about it. The second joint that no one talks about is this little joint in the back here called the facet joint. Can you see that, Henry?
Yes. Yes.
Okay. So you guys see that joint right there, the facet joint right there. Okay. See them moving? Those joints actually can become full of arthritis and cause pain. The pain from facet joints is off to the side, left and right. So most pain comes from the herniated disc, but 15% of our patients actually come back here and say, I have pain on my right side now. I have pain on my left side, or I have pain on both. And it's coming from their facet joints because the original injury to the spine, jumping off the roof with a skateboard, trying to land in your pool and landing on the concrete instead, that injury damaged not just the disc, but also the facet capsule. So that facet capsule's damaged, now it's unstable, and over the years afterwards, all that movement grinds bone to bone, creates arthritis. So you get pain in the disc, pain in the facet joints. We need to treat both. Deuk Spine Institute has a painful disc fix, which you just watched, it's the Deuk laser disc repair. We have a painful facet fix, which you just didn't watch, which we do plasma rhizotomy. We did one this morning. We didn't broadcast it because we're not ready yet. It's a proprietary treatment I developed, and it's going to be patented, and we're not going to let the cat out of the bag just yet. So that said, this patient may have some facet joint pain, which we might have to treat later. Great question.
All right, this next one comes from Valen on YouTube, and they asked, how do you treat lumbar spinal canal stenosis?
How do we treat lumbar spinal canal stenosis? That's from Valen. Valen, great question. So, lumbar spinal canal stenosis, what is it? Well, Valen, there's 4 areas of the spine that get stenosis. Okay? And just so everyone understands, I'm going to turn the spine so you look down the long axis of the spine. There's what's called central canal stenosis, which happens in the middle, which never happens. It's very rare. There's lateral recess stenosis, which is, I'll say some words that are going to confuse you a little bit, but Valen, you'll understand, but the rest of the audience may not. The lateral recess is, this is the pedicle. The lateral recess is medial to the pedicle. It's just under the facets. That's the most common cause of symptomatic stenosis. Then there's foraminal stenosis, which happens directly between the pedicles. And then there's extraforaminal stenosis, which is extremely rare. So you have central stenosis, including paracentral. You have lateral recess, foraminal, extraforaminal. Those are the 4 areas. The number 1 cause of radiculopathy or pinched nerves from stenosis is lateral recess stenosis. And this surgery treats lateral recess stenosis.
All right, this next question comes from Dr. Dalit on YouTube. And they said, sir, don't you use BMAC or PRP in post-procedure for degenerative disc or platinum plug or fibrin for regeneration?
Great question, doctor. Thank you for asking. No, we don't use anything unnatural at this time. And we have a saying, the proof is in the pudding. If you have something that works and doesn't have complication, you keep doing it. So when you look at complications from spine surgery, the more complex you make the surgery, the more complications you get. And the truth is, doing the same procedure for 16 years the same way, we don't put anything in the disc. We don't put BMAC. We don't put PRP. I tried PRP. I tried stem cells. And what happened was the inflammation that was created in the back of the disc from the PRP and stem cell was so robust, so massive, that it created pain in that patient after surgery for 3 months. And then suddenly it went away. So the one time I tried stem cell PRP in the disc when I was finished, it was a horrible result. The patient was miserable. I'd never seen them miserable before. It was the first time ever. It was so dramatic, I never did it again. So I don't use BMAC or PRP or stem cells or anything because it's not necessary. The disc will heal naturally. The only reason that the disc cannot heal naturally is because once the tear happens, the nuclear material pushes into the tear. The collagen cannot reseal through the nucleus pulposus. The nucleus pulposus is extremely pro-inflammatory. They've done studies in the lab, in vivo, in vitro, putting the nuclear material on a graft that's vascularized, and you can see the inflammation is massive. So when I saw these studies, I realized what we were dealing with was an inflammatory condition that had to have a debridement and did not need anything added.
All right. This next question comes from Doreen on Facebook, and they ask, "What is chemical irritation?" I think we were talking about that.
Yeah,
earlier.
what is chemical irritation? So Doreen, chemical irritation is irritation of pain, nerve fiber endings, what are called type 4 or type C fibers, which are not myelinated or unprotected nerve fibers that are involved in the transmission of pain signals in your body. And when those pain nerve fibers get stimulated to send signals to the brain about pain, we call that irritation of those fibers. So what causes those fibers to be irritated? The answer is inflammation, specifically inflammatory mediators. And examples of inflammatory mediators, these are called cytokines and molecules that are invisible, that are produced and released by cells that are involved in the inflammatory process. They release it locally where there's inflammation, and that it gets on the nerve fibers and stimulates the nerve fibers to be activated. They send the pain signals to the brain. So chemical irritation comes from inflammation. The inflammation is the cause of the chemical irritation of the nerve fibers, and the inflammation is coming in the back of the disc where the tear is and the herniation is. That's what causes back pain. That's what causes radiculitis, which is inflammation of the nerve root, causing leg symptoms. Great question.
Awesome. Following that question, it comes from Janice on Facebook, and she asked, "How do you stop inflammatory process in the spine?"
Great question. How do you stop the inflammatory process in the spine? You just saw how we stop the inflammatory process. It's the Deuk laser disc repair. We clean the nuclear jelly, the herniation, out with a laser, and then the inflammation goes away immediately. Now, that doesn't work for facet joints. We cannot stop the arthritis in the facet joint. So what we do instead is we deaden the nerve. We kill the nerve that transmits pain signals from the facet joint to the brain. It's a selective procedure. It's called a selective rhizotomy. Yes? Keep going.
The last question we have is from Valen on YouTube, and they ask, "Can you substitute the laser with the radiofrequency ablation? Thank you very much."
Yeah, Valen, very nice question. So Valen is clearly understands the what's going on in endoscopic spine surgery, and it sounds like you're a surgeon You probably are practicing, I don't know where you're practicing, but you're asking about whether we could use a radio frequency probe instead of the laser. The answer is no if you want great results. Yes if you want mediocre results. That's all I can say.
And that is it.
Well, thank you all for joining us. I appreciate all the questions and interest. I'm Dr. Ara Deuk-Majan, CEO and founder of the Deuk Spine Institute, and I'm here along with the other person who does research with me. Hi, Arius. Psst. He has his AirPods in. Arius has just completed a study with me on thoracic Deuk laser disc repair, and we're going to be publishing a paper on that hopefully soon if it gets accepted, where we'll give you our results on the Deuk laser disc repair transforaminal endoscopic procedure done on thoracic disc herniations for thoracic pain and radicular pain. We have a 99% elimination of pain, 1 year, as a matter of fact 14 months, so more than a year after the surgery on average with our group of patients called a cohort. And that is a big deal. We're submitting that to the Southern Neurosurgery Society, which will make a decision next month about our paper. But other than that, Arius is off to Princeton next year. He got accepted. He's going to hopefully follow in my footsteps, but we'll see. He's put his racing career aside, and he's decided to go to university and be educated there instead. Have a nice day. We'll be back in 30 minutes for our last surgery.